Now, let's talk about teriparatide. Now, this one might surprise you a little bit. So it's basically a fragment of the parathyroid hormone. The parathyroid hormone receptors aren't just in the bone, they're also in fat tissue. Most people who diet end up losing bone density along with fat and muscle. So this teriparatide can actually flip that script. So studies are suggesting that it may actually help reduce visceral fat, that deep belly fat that surrounds your organs and drives metabolic disease. It also releases hormones released by the bone to improve insulin sensitivity and even muscle performance. So we're looking at a compound that ties together bone, fat, and muscle, which is kind of like the holy trinity of aging. It could allow you to lose visceral fat while strengthening your bones at the same time. Hello, everybody. Welcome back to the Kris Gethin Podcast. Today, we are going to take a deep dive into some new GLPs. Not all of them are GLPs. Well, they can be classed as GLPs, but not in their traditional form. Now, over the past few years, we've just seen an absolute explosion of interest in GLP-1 receptor agonists and related therapies, and these compounds are really changing the way we think about obesity or diabetes and weight management. But while like the semaglutides and the tirzepatides have been dominating the headlines, there are several upcoming drugs and compounds that deserve attention. One of them, retatrutide, I've spoken about in a previous show. But now today, we're going to talk about a couple of others, namely one called, and wait for it, these are all mouthfuls. I don't know who comes up with these names, but Afoglipron, okay? This is the very first oral non-peptide GLP-1 receptor agonist. And then we have Teriparatide, which is traditionally a bone health drug, but it's showing some interesting effects on fat regulation. Then we have Mazdutide, which is a dual GLP-1 and glucagon receptor agonist that could take fat loss to another level. And then we have Tesofensine, which isn't your traditional like GLP, but you'll find it on a lot of research sites, which is an appetite suppressant with a completely different mechanism of action. But we'll take a deep dive into how each one of these works, what the data so far is showing us, the potential benefits and risks, and how they might fit into the bigger picture of health, fitness, and longevity. But remember, I'm not a doctor. I'm not a physician. Do not take this as medical advice. Go check it out with your doctor. And remember, these compounds that I'm talking about are for research purposes only. Okay. But let's talk about the first bad boy here. Okay. And that is Afoglipron. Why is it such a big deal? Well, I'll tell you why. Because it's the first oral non-peptide GLP-1 receptor agonist. Pause and think about that for a second. Because until now, GLP-1 drugs like your semaglutide or your tirzepatide or retatrutide require shots. Some do weekly, some do micro doses of like daily shots, whatever the protocol. And while that may not sound like a huge deal to someone motivated or who's used to it and always been a barrier, but it has always been a barrier for the general population. Not many people want to inject themselves. They're not willing to do that even once a week. So that's a breakthrough that you're going to get with Afoglipron. It's an oral capsule. You swallow it and it activates the GLP-1 receptor just like the injectables do. Now, mechanically, Afoglipron still works the same way. It slows the gastric emptying, so food stays in the stomach longer. It reduces the appetite by acting on the brain's center to tell you that it's full. It improves your insulin sensitivity and supports that blood sugar control. But here's the kicker. Because it's a non-peptide, it doesn't get broken down in the gut the way that injectable peptides would, and that makes it much more stable and usable as an oral drug. And clinical trial data so far is quite promising. People are seeing weight reduction in the ranges of like 12 to 15% of total body weight. So that's kind of in line of semaglutide, but with a convenience of a pill, basically. But let me pause here and ask you this. Like, do you think compliance rates are going to be higher with a pill than injection. Well, of course it is. Who cares about throwing a pill down their throat? A lot of people will not go out there and purchase insulin needles, even if it's a small subcutaneous pin that they got to put inside themselves. They just don't want to do it. So, even the best drugs in the world won't work if people don't, quote unquote, stick with it. But the side effects, they're pretty much the same as other GLP-1s. Some people could get nausea. They could have the occasional GI upset. But that seems to be, the cost of entry with this class of drugs for some people. But that's why a lot of people will prefer to microdose. And you think about it, with this capsule, you are pretty much microdosing. And the moment that you take something oral, it makes it so much more appealing to the average person. For athletes and fitness enthusiasts, the implications are nuanced. On one hand, appetite suppression could be a double-edged sword. If you're at a cutting phase, it's a godsend. But if you're trying to bulk or gain muscle or fuel intense training, having no appetite could be a problem. But this is a potential game changer. Now, if you're watching a video, you'll see I've actually got one in front of me here. It's called tirzepatide. Now, there's different trials from what I remember. I think it's from 6 milligram was one trial, 16 milligram was another, and I think 30 milligram capsules was another one. You can check out the trials, or I could put them in a link in the show notes here. But I've got it here, and I've actually been testing it. It definitely does subdue the appetite, but not to the extent like other GLPs where you kind of feel sick, or you look at food and from a psychological perspective, you're like, there's no way I'm going to eat that. You can still eat on it, but it will cut out and cancel a lot of the food noise. Now, even though I'm holding a bottle here, this probably isn't going to be available for medical use, I should imagine, until, say, maybe 2027. Of course, there's research sites that are selling it right now, and people are actually taking this. Much like your Teriparatide is probably not going to be available for at least a year, but people are taking that. So that's the exciting thing, is that there's a lot of people, obviously, based on the research and hopefully not taking too many risks, are seeing great results on this oral peptide. So that is the actual game-changing aspect of this, is that you're not having to travel with a cooler, with your needles, with your vials, keeping it stable, mixing it, etc. It's just, you pop it back. Now, there are obviously alternatives, natural alternatives that you can take. Of course, there's a 2-shred that I've got, your AM and PM formula, but there's some people out there that are just addicted and controlled by food, much like people are with drugs or alcohol, so this is where it can really help. Now, let's talk about, another mouthful, Teriparatide. Okay, now this one might surprise you a little bit because it isn't new. It's been used for years to treat osteoporosis, but under the brand name Forteo. So it's basically a fragment of the parathyroid hormone, and it's given as a daily injection to stimulate bone formation. So why are we including it in this conversation about fat loss and appetite suppression? Because there's a fascinating part to this. The parathyroid hormone receptors aren't just in the bone, they're also in fat tissue. So when you stimulate them intermittently, the signal doesn't just go to the bone, it seems to affect how the body partitions the energy. So studies are suggesting that it may actually help reduce visceral fat, that deep belly fat that surrounds your organs and drives metabolic disease. So think about that. Most people who diet end up losing bone density along with fat and muscle. So if you think about people, on Semaglutide, Ozempic, they're not getting the nutrients into their muscle and into their bones as they should in order for it to recover, replenish, and regrow. So now they're actually putting themselves in deeper health consequences because now they're becoming deficient in those muscles and in their bones. So if they're dealing with osteoarthritis before, chances are they're now speeding up that process. So this Teriparatide can actually flip that script. So it could allow you to lose visceral fat while strengthening your bones at the same time. So that can be quite a combination for longevity. It also releases hormones released by the bone to improve insulin sensitivity and even muscle performance. So we're looking at a compound that ties together bone, fat, and muscle, which is kind of like the holy trinity of aging. But of course, there's caveats. So teriparatide has only been used limited. It's only limited to about 2 years because of the concerns about bone tumors in animal studies. So whether that risk applies to humans at therapeutic doses is debatable, but it's still on the radar. So it is potential. It does have potential as a dual purpose therapy, improving bone density and reducing harmful fat, and maybe enhance metabolic flexibility. But it's not at the front line as a fat loss drug. But it is a tool that has some very interesting applications, but I'd really like to see more research about the health and safety data of that. Now let's move on to Mazdutide. Okay, so this is what I'd call like the second wave of GLP drugs because it doesn't hit the GLP-1 receptor. It's a dual agonist, the GLP-1 and the glucagon. So let's break that down. We know that GLP-1 agonists reduce appetite. It improves insulin sensitivity. It helps you eat less. That's clear. But what does glucagon do? Now, normally, glucagon is the counterbalance to insulin. It raises your blood sugar levels by telling the liver to release glucose. But it also has another trick up its sleeve. It increases energy expenditure. It revs up your metabolism. So Mazdutide is designed to combine the appetite suppression of a GLP and a fat-burning metabolism-boosting power of glucagon. So think about that for a moment. Eat less, burn more, holy grail of fat loss. Now, the trial data so far is quite eye-opening because patients are losing between 15 and 20% of their body weight. Now, I didn't say body fat, I said body weight. So that starts to approach the kind of results that you'd expect from, gastric bypass surgery without the surgery. But the obvious concern here is, won't the glucagon spike blood sugar? Good question. And that's where the genius of this dual agonist comes in. The GLP-1 side offsets the glucagon's blood sugar effect by stimulating insulin. So you get that fat burning without the uncontrolled glucose spikes that leads to insulin resistance. So the side effects, again, much like GLPs, are usually GI related, similar to like semaglutide. But researchers are watching liver stress closely, since chronic glucagon stimulation could theoretically tax the liver. So, theoretically, again, for athletes, Mazdutide could be especially interesting because it's not about appetite suppression. It actually increases energy expenditure at a different angle. Bottom line, it represents a next evolution in GLPs, of course, but we also have the tirzepatide, and in my opinion, the personal favorite is retatrutide, that GLP-3 agonist where you have the GIP, you have the glucagon and the GLP-1 all in one. So again, that's still leading the charge. But let's talk about Tesofensine here. So this is unlike others because it doesn't touch the GLP-1 at all. Instead, it's what's called a triple monoamine reuptake inhibitor. That means it blocks the reuptake of dopamine, norepinephrine, and serotonin. So if that sounds like a lot to mix in, like, say, it sounds like a lot like a mix of like an antidepressant and, say, a stimulant, it's because it is. So how does that translate into fat loss then? Simple. It boosts these neurotransmitters. Tesofensine reduces the transmitter to reduce appetite. It blunts your cravings. It increases fullness. But the story gets a little bit more interesting there. Tesofensine was originally investigated for Alzheimer's and Parkinson's. But when they did those trials, the researchers noticed something different. The patients were losing weight, and a lot of it. So that led to quite the pivot into obesity studies. And the result, in phase 2 trials, Tesofensine produced about 10 to 12% weight loss over 6 months. And it didn't slow down gastric emptying. It worked completely on the psychological aspect of that person. So the benefit here is tesofensine goes straight to the brain's reward and hunger center, or the GLP-1 drugs slow the gut and influence fullness indirectly. And tesofensine targets the psychological drive to eat. Now, of course, there are side effects because it acts like a stimulant. You may have an increase of your heart rate, in insomnia, in anxiety. So it's not without risk, especially for people with cardiovascular issues. But I have had clients, not me personally, but I've witnessed clients taking like 500 mcg, not a problem whatsoever. They don't even know that they've taken it, other than they just don't feel hungry. Then I have other people who have taken like 200 micrograms, and they are wired. They feel sick. Their heart is racing. They can't sleep. So everybody is very, very different, and it's dose dependent. Okay. So, but it is a powerful combination. It could be like a GLP-1 drug that blunts physical hunger. Then a tesofensine blunts the craving, the mental urge to snack. It's like attacking the appetite from two different directions at once. That's why quite a lot of people stack these with their GLPs. So it is like phonological willpower, but again, the trade-off is the stimulant-like effects. So to wrap that up, we have, of course, as we started, which is, I guess, to me, the most exciting out of the lot, and that is Afoglipron. That is the first oral GLP-1 agonist breaking that injection barrier. Then we have the Teriparatide, that bone drug that also reduces visceral fat, improves insulin sensitivity. Then Mazdutide, that dual GLP-1 and glucagon agonist, which could rival some, surgery level fat loss, basically. And then Tesofensine, that brain-based appetite suppressant that directly tackles cravings. So each of these compounds take different approaches. Some focus on the gut, some focus on bones, some focus on the brain, but the common thread is they all target the problem of obesity, the dysregulated appetite and energy balance. But ask yourself, what happens when these therapies become widely available, affordable, and possibly even stackable? Are we heading towards a world where obesity is finally manageable? Or are we opening Pandora's box where people outsource discipline for drugs and forget the fundamentals of training and nutrition and sleep and hydration and lifestyle? So that's the debate, and one that I'll probably keep returning to. So thanks for tuning in. If you found value in this deep dive, share it with someone who wants to understand the future of fat loss. Refer back to the other podcasts where I spoke about the top 3 GLPs individually. And please do share this, like this. If you do have any questions, please let me know. But in the meantime, subscribe, and I will see you here for the next Kris Gethin Podcast. Thank you very much. I am out.